Now moving on to the presentation, which is on obesity and kidney and nephrologist perspective. I'm sure by now you would have all got a brief idea from Gopalakrishnan sir, a quick overview. Now let's have some more detailed analysis of this topic. Now let's have an opening question. Why are some kidneys failing faster than expected? Let's take two patients, same eGFR, same duration of diabetes, same medication regimen, same proteinuria. One patient progressing rapidly compared to other. Why is it due to? Of course, there are multiple variables, but one of the significant variable is obesity. So obesity is a cause of CKD. It's a cause of CKD progression, and it is a cause of cardiovascular risk multiplication. So the take-home message is obesity should deserve the same attention as we give to proteinuria. Now, if you analyze the epidemiology, there is a significant rise in the prevalence of obesity. In fact, we can see a parallel rise in obesity, diabetes, and CKD, a sort of triple epidemic curves. So as obesity rises, diabetes and CKD follow, their prevalence increases, amplifying the burden on individual as well as on the health system. Now, what we as nephrologists, for analyzing the kidney health, we routinely measure serum creatinine, eGFR, and albuminuria. We often ignore obesity. This is nephrologist's blind spot, in fact. Now, what do you mean by obesity? Is it just the body weight? Body weight is not an absolute measure. So we have to measure fat mass, visceral adiposity, and weight trajectory, which I will be explaining in the subsequent slides. So how obesity damages the kidney? So we can say there are four major pathways. 1, hemodynamic stress. 2, metabolic stress. 3, inflammatory stress. And 4, oxidative stress. Now moving on to hemodynamic stress, which already Gopalakrishnan sir has explained. So obesity increases the total metabolic demand, and kidney respond with increased renal plasma flow and increased GFR, and there is increased sodium delivery to the distal tubule and macula densa sensor, and there is increased glomerular hyperfiltration. So there is increased renal plasma flow, increased afferent arterial dilatation, and increased glomerular pressure, resulting in glomerular hyperfiltration. So because of this, there is podocyte stress, glomerular sclerosis, interstitial fibrosis and tubular injury, and CKD progression. So what is the price of this hyperfiltration? There is chronic glomerular hypertension, which results in glomerulomegaly, podocyte stretch, podocyte loss, and segmental sclerosis. In the right side, you can see on the screen, the past change showing the perihilar segmental sclerosis, the background of an enlarged glomeruli. So predominantly perihilar segmental sclerosis is noted as a result of this hemodynamic stress. Now, second pathway, metabolic stress. See, visceral fat is not an inert fat. It acts like an endocrine organ. It produces several free fatty acids. There is increased production of leptin, resistin, and several other inflammatory mediators. And as Sir rightly told, there is increased production of aldosterone releasing factor and increased aldosterone production. So everything culminating in insulin resistance and renal lipotoxicity. So lipid nephrotoxicity or renal lipotoxicity is a significant contributor to the obesity-related kidney injury. So in obese individual, there is excessive free fatty acid and triglyceride-rich lipoprotein accumulation in the tubular cells, and tubular lipid accumulation resulting in mitochondrial dysfunction and reactive oxygen species generation, which results in inflammation, tubular cell apoptosis, and interstitial fibrosis, resulting in ORG as well as CKD progression. Now, insulin resistance is another mechanism by which obesity damages the kidney. See, visceral obesity resulting in insulin resistance and resulting in hyperinsulinemia, causing sodium retention, hypertension, and CKD progression. And inflammatory stress is yet another pathway. See, adipose tissue secretes pro-inflammatory cytokines like TNF-alpha, IL-1 beta, interleukin-6, MCP-1. So obesity is a stage of chronic low-grade inflammation. So this chronic inflammation and insulin resistance both result or predisposes the individual to a higher incidence of renal cell carcinoma. Now, The fourth mechanism is oxidative stress. So there is increased oxidative stress, reactive oxygen species generation in obesity. There is endothelial dysfunction, tubulointerstitial fibrosis. So the whole take-home message is obesity accelerates renal aging. Now coming to obesity-related glomerulopathy. So it is not merely obesity plus proteinuria. It is a distinct clinico-pathological entity. So obesity results in hyperfiltration, glomerular hyperfiltration. There is increased RAS activation, insulin resistance, increased secretion of leptin, resistin, and pro-inflammatory cytokines and inflammatory mediators from the visceral adipocytes, reduced adiponectin, which is the protective factor, which all culminates in increased intraglomerular pressure, glomerular hypertension, glomerulomegaly, podocyte damage, mesangial expansion, and FSGS, predominantly perihilar variant. So the classical clinical presentation of ORG, it includes, there is a history of long-standing obesity, enlarged kidneys, proteinuria is there, but usually subnephrotic range and often no edema. Why no edema? Unlike classic nephrotic syndrome, in this case, serum albumin is often preserved and hyperfiltration is the predominant mechanism. So obesity-related glomerulopathy does not have a gross nephrotic syndrome picture. Now, when we analyze the light microscopy, we can see there is glomerulomegaly and FSGS lesion, commonly perihilar variant. So the right side is the pastine showing the perihilar fibrosis, perihilar focal segmental sclerosis, and the glomerula is enlarged. So this is again showing enlarged glomerulus with segmental sclerosis involving hilar region. And if you take the electron microscopy, it is like secondary FSGS. You don't get diffuse food process effacement. It is the focal one. And why perihilar? Hemodynamic stress is maximal near vascular entry. Therefore, perihilar segment is injured first. So it is like histology mirrors pathophysiology. Now, obesity is a CKD multiplier. Whatever be the primary disease, be it IgA nephropathy, diabetic kidney disease, hypertensive nephrosclerosis, ADPKD, whatever be the primary disease, obesity accelerates CKD progression. Now, various mechanisms I already discussed with you, the hemodynamic stress, metabolic stress, lipid nephrotoxicity, hyperfiltration, and glomerular sclerosis culminating in CKD and resulting in progression of CKD. Now, obesity and OSA. See, obesity results in obstructive sleep apnea, causing intermittent hypoxia and sympathetic activation. There is nocturnal hypertension, non-dipping of blood pressure, CKD progression, and increased cardiovascular events. Now, a word on obesity and nephrolithiasis, which Sir already discussed. There is higher incidence and prevalence of nephrolithiasis in obesity. In obesity, there is lower urinary pH and increased urinary oxalate, uric acid, sodium, and phosphate excretion. And another reason is insulin resistance predisposed to nephrolithiasis through its impact on tubular sodium hydrogen exchanger and ammoniogenesis and the promotion of an acidic milieu. Now, coming to defining obesity. It's a simple question, but it's a difficult answer. See, same weight, same BMI, different complications we can encounter. So what exactly constitutes obesity? Is it BMI, which is the cutoff? So if you take body mass index, the international criteria is more than 25 kilogram per meter square means overweight, and more than 30 kilogram per meter square means obesity. And Indians, they have a lower cutoff because there is a higher metabolic risk even at lower BMI. But is BMI the standard one for assessing obesity? See, same height, same weight, same BMI, still risk will be different. BMI cannot distinguish between muscle, fat, and fluid. So individuals with same BMI can have different body composition. So central obesity is often superior to body mass index. We have to measure waist circumference and waist hip ratio. And there is something known as South Asian phenotype. That means the BMI will be normal, but they will be metabolically obese. That means thin outside and fat inside. Now, why South Asians are different? There is a preferential visceral fat deposition, and the visceral fat, as I already discussed, is metabolically active, producing cytokines, hormones, ARF, insulin resistance finally happening. Now, there is something known as YY paradox. It is introduced in 2003 Lancet commentary. That is Yajnik-Yudkin paradox. So it's basically two individuals, one a Caucasian and one South Asian, same BMI, but they had different visceral fat composition. So the YY paradox or Yajnik-Yudkin paradox, it was introduced in Lancet commentary 2003, highlights the South Asian possess higher visceral fat and lower muscle mass compared to Caucasians at similar BMIs, resulting in the thin fat phenotype. And this metabolic profile increases the risk for type 2 diabetes, cardiovascular disease, prompting recommendations for alternative health assessments beyond standard BMI. So basically normal weight appearance, but abnormal metabolic profile. So the risk follows visceral fat, not the appearance. So there we need to have something beyond body mass index. So beyond BMI, we need advanced tool for estimating total body fat percentage and visceral fat estimation. So for that we have bioimpedance analysis for estimating total body fat as well as DEXA for assessing the visceral fat. But there is something we always forget in the history, the forgotten vital history, the weight history. Let's take a 45-year-old woman with height of 160 centimeter and weight 60 kg. So almost the weight proportionate to the height, and she looks healthy, BMI normal. But we have to ask the history. So look at her history. At the age of 20 years, she was 50 kg. And now at the age of 45 years, she's 60 kg. So what is the composition of that extra 10 kg? Is it muscle mass? Is it bone mass? See, females to gain muscle mass, especially after the age of 30 and all, it's not that easy. Though even if they had gone for gym and all, the testosterone level is low. And bone mass, in fact, reduces after the age of 30, 35. So it is predominantly the fat mass. So we have to take this history when we analyze a patient, the weight trajectory. So how will you manage a case of obesity and prevent obesity-related kidney disease? So the foundation of management, as we all know, lifestyle is the platform. Always start with nutrition, physical activity, sleep optimization, behavior change, and the lifestyle, which is the platform, and everything else is an add-on. So I'm not going in depth to this management aspect. Moving on to the drugs. So we have a few wonder drugs in our armamentarium to tackle obesity. One is SGLT2 inhibitors. Now, they help in weight reduction, and the advantage is they have a preferential visceral fat reduction ability. And also they have renal protection and cardiovascular protection. So we can treat kidney and adiposity together. Now, next one is the GLP-1 receptor agonist, much discussed one in the current scenario, current days. So it has a powerful effects on weight loss, glycemic control, BP control, and albuminuria. But the important point to keep in mind is without lifestyle foundation, the weight gain can happen often following discontinuation. Now, the trials which established the beneficial effect of GLP-1 agonist, semaglutide in obesity, it showed the benefit of semaglutide in preventing the cardiovascular events. The SELECT trial was one which showed the effect of cardiovascular risk reduction effect of semaglutide. And FLOR trial, which analyzed the role of semaglutide in diabetic CKD, found that there is significant reduction in the risk and improvement in cardiovascular as well as kidney outcomes and mortality. So the message is obesity therapy is now nephrology therapy, in fact. So it's the FLOR trial showing the semaglutide having significant reduction in the major cardiovascular events as well as reduction in the progression of chronic kidney disease. Now, a word on bariatric surgery. In fact, as Sir told, metabolic and bariatric surgery, it's the most effective intervention for severe obesity. So benefits are major weight loss, reduced albuminuria, improved blood pressure, improved glycemic control. But potential concerns are oxalate nephropathy and nutritional deficiencies. In fact, in this era of GLP-1 analog, these are of less relevance at present, and maybe as last resort we can opt. And a word on orlistat, which is an old anti-obesity drug, which inhibit pancreatic lipase and inhibit the absorption of fat absorption inhibition. But the problems are poor tolerability, limited efficacy, hyperoxaluria and oxalate nephropathy are in fact a concern. So the message is not every weight loss is kidney friendly. Now a word on obesity paradox, that is obesity in dialysis. In general population, higher BMI means higher mortality. But when you come to the dialysis population, moderate obesity often associated with improved survival because of better nutrition, protein reserves, less protein energy wasting. However, morbid obesity increases cardiovascular events and hospitalization and mortality. In fact, it is like a U-shaped mortality curve. But unlike in general population, moderate obesity has a beneficial effect in dialysis population, and it is often associated with improved survival, which is otherwise known as obesity paradox. So, what are the practical obesity management algorithmic approach as far as a nephrologist is concerned? So, we have to measure obesity correctly, ask for weight history and weight trajectory, which is very crucial in coming to a conclusion. We have to assess the visceral adiposity, waist-hip ratio, waist circumference, and identify obstructive sleep apnea, which in turn is a trigger or a factor responsible for progression of CKD. Then start with lifestyle intervention, which is the foundation. SGLT2 inhibitor therapy, when appropriate, we have to start. And when indicated, start GLP-1 receptor agonist and consider bariatric surgery as the last resort. So, as a take-home message, what I want to tell you is what should change in our clinics tomorrow. OPD visit for CKD should include weight assessment and weight trajectory assessment, waist circumference, weight history. OSA screening, we can use Stop Bank score. It is there on the screen where S stands for snoring, T tiredness, O observed apnea, high blood pressure, for P, BMI more than 35, age more than 50, neck circumference more than 40 centimeter, male gender, each point getting 1 score and a score more than 3. We have to consider OSA evaluation. So that should be a quick clinical tool we can use in our OP and lifestyle counseling. So this should be part of our clinical algorithmic approach in evaluating a CKD patient in our clinic. So with this, I conclude my talk. Thank you.